our orthopedic fraternity and in the literature also, they are using the THR as a tool to come out for IC fractures, even a little younger groups also, like 55, 60, like that. Because what the claim what they are doing is anyhow this THR is going to survive for 20, 25 years. Then once in a lifetime it will be completed and patient will be more comfortable. If you do the bipolar or hemiarthroplasty, it is going to worn out within few years. So again we will subject it to surgery. So that is a claim they are making it. And moreover, the main limitation of THR is we can able to squat or cross leg. But nowadays, most of the people are not needed the squatting or using the rest and type of these things. So that's why the patients also being convinced with that logic. So on that ground, your comment on normal tabulum.
So that's a good question. Actually, I expected it. I have not put in my heading normal tabulum because actually, a professor asked me, one student can ask me, 20 years back, if I tell somebody totally for normal tabulum, we used to fail. Of course, it's not me, my colleagues. So it's a good question. Here answer is two things. One is fixation or orthoplasty. Again in orthoplasty, hemiarthroplasty or totally. Let me clarify. Number one, fixation. If the bone stock is good, if the patient is active and is not having any comorbidities, his life expectancy is more. And reduction wise, if you get a very good reduction, most of my previous speaker told reduction is remark. I mean, most of the speakers told in their any India or fever, wherever, reduction is important. I mean, your first slide. So if that is there, fixation is the answer. There is nothing, don't do totally for a patient who is having good bone stock, young and energetic, even if he is 60 years, fixation is the answer. But I am telling the situation where posterior comminution is there and the patient, though he tells 50, is looking like 65, alcoholism, moving with some Parkinsonism, some problems are there. In that situation, to cope up with it, probably some replacement is required. Again, another important question is hemiarthroplasty or total. Hemiarthroplasty, if you do at 50 years, though I have seen some cases of even 20 years have followed good, but not all the time. That depends upon the osteoporosis of the bone and also some great factor which I don't know. Some things are failing very much. In that situation, when you are having a good technique in your hand, that is total replacement, and design also changed for last 20 years. It was cemented strongly, of course that is also survived for a long time, but now we are getting a very beautiful designs in the total, which will survive at least 20 to 25 years, especially ceramic on poly. The ceramic has made a world little different. In view of this, at a 55 years, where fracture is not able to fix it, if you ask me choice between hemiarthroplasty and total, I will go for total. Because hemiarthroplasty may cause some problems, requires revision of that hemiarthroplasty total. Conversion of hemiarthroplasty totally is another big question. That is different operation, having a lot of headaches. So, in that situation, at that age group, that is between 55 to 65 or 70. I am not telling any particular age. This is the age cutoff, not like that. We have to see each and patient may decide all these things. Then you have to do. At the same time, 85 years, I don't advise totally palliatives. Go for hemiarthroplasty. Because at that age, doing such a thing, he is having low BP, heart problems, tense, so many things. Going on struggling for a total lip and dreaming, not correct. Quickly go, put the hemiarthroplasty. Like this, we have to go depending upon the case, depending upon his general condition, depending upon his activity, depending upon his occupation, depending upon his relatives thing. Now we are doing one study, whether patient being left after his mother, his daughter-in-law, son-in-law, how far they are giving food, how they are looking after is very important. 1 year later, we have seen 80% of the people have not survived. For your kind information, we have done this study. After 75 years, if you do either PFN or total lip or hemiarthroplasty, they are not surviving. Reason is, the support, the social, family support is very important. All these things factors we have to consider. So with this, I think partially answered. Still for an normal tabulum, totally is not.
Thank you very much, sir.
Experience on that.
So till now no plate has been removed because this set of patients, they don't come back. The idea of doing single stage surgeries, they won't come for the second surgery. So plate removal is out of question. One case I remember, we have a series of 30 odd cases now. One case I removed a plate because the plate was broken. So that is one which I revised. Otherwise no elective implant removals, because most of them, they have some amount of knee range and they are happy with that. So no implant removals.
If they come, do you think it is to be removed or we need to counsel them that
No, it depends on the robust reconstruction, how much graft I have put inside and how much whatever graft I have put, as it regenerated some more graft into it. Because usually if you put less graft, it is not going to get adequate strength and the plate should be there. But if both the columns, anterior, posterior, all four columns are intact, then plate removal shouldn't be a problem. That for a routine sound orthopedic principle, that's all. Yes.
Nothing like a time limit or anything.
Nothing like a time limit.
Sir, for you, sir, you have been a senior orthopedic surgeon doing trauma for a long time. So my question is, there is a locking plate principle now come up with an anatomical plate, what they are saying. Especially in a posteromedial plating, when we do for a tibia, we have been using these anatomical plates. These anatomical plates are not for the Indian scenario, and we see a lot of tibia vara here. Are we overcorrecting it by them using these anatomical plates? Do you think that we need to have a new generation of plates which will fit, or contouring or something more is needed?
Great. Sometimes what the plates that are available on the table, the instrumentation set, whatever the AO or anything that these companies give, they will not really abut. Okay. One is you can manipulate them and position them. And the other thing is you can do actually a fragment fixation, interfragmentary fixation if the fragment allows, and then do a buttressing with a different kind of plant. That's the concept.
Yeah, that's the thing, but I want to know from you that with your experience, what all the locking plates you have been using all these days, do you think that there is a revisit is needed for a separate curvature of plates for the posteromedial thing?
No, actually.
In terms of design.
Yeah. In my experience, whatever you're asking me, that most of the time we have been using the AO implants. And the AO implants, as I told you, majority of the time they do suit. Sometimes only they'll be standing off. So I do a little bit of bending and using them. Now, probably a study is required to actually study the posteromedial condylar anatomy, and the recontouring of the plate or the pre-contouring of the plate has to be done according to that.
If you think about the locking plate principle, it is an internal external splint. Okay? It is an internal external splint. It doesn't matter whether it's sitting on the bone properly or not. The reduction matters. If you reduce it properly and put your plate properly, that stays. So I don't see any need for that. If you think about the principle of how the locking plates work.
Most of the time we use them as a buttress are there.
Yes, sir. It's an internal external splint. You reduce the fracture first, which will stay there.
Posteromedial condylar fracture needs a proper buttress. Okay, it is just like the distal radius or something like that. So where the contact has to be there properly, particularly at the apex, and also as high as possible. So that is a contouring and a proper contact there is required. The first screw you put will be not in the fragment, you put the bottom, not the bottom, one screw just below the apex, so that it buttons. So
Thank you, sir, for your nice insight. Now we request our chairpersons to honor the guests. Come.
thanks to organizing committee for giving the opportunity to chair this session. I request organizing committee.
I request Dr. Tati Srinivas Rao sir, Dr. Vivian Prasad sir, Dr. Vivian Prasad sir, Dr. Hari Sharma sir, Dr. Hari Sharma sir, Dr. Raju Iyengar sir, Dr. Ratnakar Rao sir, Dr. Iyengar sir, Dr. Ratnakar Rao sir, Dr. Bangari Swami sir. Now I request Dr. Ramkumar Reddy sir to honor our chairpersons. Dr.
I call our
Dr. Sambara sir. Dr. C. Hariprasad sir. Dr. P. Kali Prasad Rao sir. That is on ortho technology. I would like to invite our chairpersons, Dr. M. Nagendra Babu sir, Dr. Srinivas Reddy sir, Dr. V. Suresh Kumar sir. Please come onto the dais. I request our first speaker, Dr. Ashok Sham sir, to come onto the dais and give a talk on social media and orthopods, do's and don'ts.
Of the CME has come, which is very important for us, all of us nowadays, because we know technology is the gateway to knowledge, gateway to practice, everything for the publicity, and we are very lucky to have two eminent personalities in ortho technology. One is Ashok Sham and Dr. Neeraj Bijlani from Mumbai have come. Thank you very much for accepting our invitation and coming from a long way. Thank you, Dr. Ashok Sham and Bijlani. And Ashok Sham is the chief of this Ortho TV, which we are coming across in the past few years, and especially in the COVID time. We had many webinars, and which have imparted good amount of knowledge to all of us, where the time when we didn't have these conferences. Okay, thank you very much. Dr. Sham, you can start.
Thank you, Dr. Srinivas, and thanks the organizing committee for inviting us. So I'll start with this case. So this is a 40-year-old gentleman who had a twisting injury to the feet and presented to an orthopedic surgeon. This is like a borderline injury. So he was given two options. The first surgeon advised him surgery, and the second surgeon advised him to conserve. The patient went for a second opinion. The second surgeon said, we can very well treat it with conservative manner. What happened next is surprising. So the patient posted this on Facebook, and he challenged the intention of the first surgeon, talking about his ethics, talking about his motives of advising him surgery. And this was read by more than 22,000 people within 2 days. This kind of situation is scary for us. It is like a mob coming to our hospital. It's like a mob coming to you on social media. So how to deal with that? To deal with this situation, the best way is to know about such situations and to know about such platforms and to make ourselves aware about do's and don'ts on social media. So that's what my talk is today, and let's begin with what is social media in general. So there are a lot of definitions and talk about how social media is. What I'll say is it is kind of information transmission which is highly competitive in a small, in a restricted, limited network which is huge in its own. Okay, it's a contradictory word, with a very short attention span of people who are using it. All these three factors play a very important role if you want to understand that. And these are the big five that I'm going to speak on in some details. So I'll share with you a story that began in 2007. when the ceiling was still under construction. So we started something called as Indian Orthopedic Research Group on Facebook. Okay, this was first started on Facebook as a page and then as a group way back in 2007. Over a period of time, more than 26,000 orthopedic surgeons are part of this group. There are daily case discussion, interactions that run into thousands every month. And this again developed into something called as Ortho TV, which people came to know during COVID, but we launched it in 2012 itself. Now Ortho TV itself expanded the network and went to 45,000 orthopedic surgeons across the globe. What I'm hinting at is that social media is such a powerful entity. It can be used it was started with individuals, and it can be used to outreach thousands of people. So it is a medium of communication, it is a medium of interaction, and it is a medium of where you can influence a lot of things. So that's the reason why it is so powerful. And the question is not that whether you will use social media or not. In this world and in the coming future world with the future generation, it will be essential for you to use social media. The question is how appropriately you can use it. So that's what we are going to see. Some do's and don'ts. A lot of these are taken from Neeraj, so I acknowledged it. One of the first do's and don'ts is when you are on social media, you also want to be as a social person and you also want to be as a surgeon. So keep separate account for social media, one for personal use and one for professional use. For example, here this is Neeraj's personal account where he shares his photographs personal, and then there is the professional account where he shares a lot of patient education material and other information. So keep your social accounts different. One professional, one personal. So that's the first do. Don't befriend patient or talk to them on social media. Okay, that's a lot of patients will start contacting you on social media, especially on WhatsApp and Facebook. If you have shared your WhatsApp number on Facebook, you'll get calls. Don't befriend them, guide them to your clinic or to your place of where you're consulting. So that's the first don't. There is Neeraj who's gone for a vacation. This is, I think, in Phuket. And he posted one photograph before he had the different accounts. And patients started commenting on it. So that's not a good scenario at all. So separate your accounts and don't interact with patients. So that's the first do's and don'ts. Second do is include consent in the video. So this was a surgeon in my city of Thane who got arrested because he started posting patient video in treatment. The patient noticed it after 2 years on YouTube and he complained and the surgeon got into trouble. So take consent, hide the patient identity. Even if you have consent, you need to hide the identity. Don't post surgical and bloody videos on Facebook or any other platform. Generally, what Facebook does is it covers it, but still you have to be careful not to post. Most of the people will not understand, not relate to it. So don't do that. Don't post any medical information, your surgical details in forums which are non-medical. You have friends groups, you have groups where financial groups or other groups. You don't want to share your details on these groups. Okay, for example, you have done a THR and you're posting in your friends group. It doesn't look good at all because they can't relate to it, they can't understand. If you've done some landmark thing with your hospital or a clinic, then of course you can post as a social post. You can do this in terms, like I said, don't post something which is bloody and etc. But you can always post positive things, positive review about your patients. You can post about any camps happening for patients which can help them. So a lot of these also come into news. There were 3 doctors who shared the C-section of a triplet, and that got into trouble for them. This was from Thiruvananthapuram some years back. So restrict yourself what you are sharing, especially with patients, and keep the identity in restricted. This is again very important and very current scenario with what happened in Rajasthan few days back. So avoid any communal hatred or political views. as a surgeon on your professional place, please avoid them. Again, there is, like I said, the question is not that whether you want to use social media or not. All your patients will be using social media, and almost 50% of patients now, even in rural areas, are searching the surgeons online and then come to you. So I'll provide you an overview of the most commonest of these platforms where the patient will get information and how to present yourself in those platforms. For example, somebody searches me and he gets my LinkedIn profile as first. So this is what my LinkedIn profile looks like. So I put a banner up there where the headings under which I wish to be known are put up. So you can put up your specialty. So you can put up as orthoplasty, trauma, and whatever you wish to be. So I have put up what I need the patient to know, and this is a free profile which patient can access. LinkedIn is a very, very professional network. Okay, so this is not a casual network.
Kind of ironic, ain't it? How these touch screens can make us lose touch. But it's no wonder in a world filled with iMacs, iPads, and iPhones, so many eyes, so many selfies, not enough us's and we's. See, technology has made us more selfish and separate than ever. Because while it claims to connect us, connection has gotten no better. And let me express first, Mr. Zuckerberg, not to be rude, but you should reclassify Facebook to what it is, an anti-social network. Did you know the average person see?
Okay. Let me see. Yes. So, I have been taking this lecture for the last 7-8 years, and this was one of the imaginary things which I used to tell everybody that in the future this is going to happen. The syllabus this year has the following apps. But in 2020 this was the reality. That all our children use many apps for their education. They use exam.net, they use Zoom, they use Google Meet. So this has now become the tomorrow's future today. So I'm going to show you some smart apps. All of you use a smartphone. Is there anyone here who doesn't use a smartphone? Can you raise your hand? Okay, good. So everybody is using smartphone. And at the end of the lecture, people may feel that we are not an orthopedic surgeon. So I would like to stress that we are also an orthopedic surgeons. Me and Dr. Ashok, we are into practice. I am into practice, and also we are the co-founders of Ortho TV Global. So the most common app which all of us use is WhatsApp. And as he told that it is very important for us to have all the privacy settings on. So let me take you through this. Consider this not as my didactic lecture, but as a workshop. I would request all of you to open WhatsApp on your phone and go into this screen. So this is my WhatsApp, and in the iPhone on the right side bottom, can you see it? Oh, sorry. Now can you see it? Okay. Now, check. Privacy. If you can see, my last scene will always be nobody. So what happens is that many of us will be getting up in the middle of the night and there will be some notification and we may just by chance put on the WhatsApp and then go back to sleep. So if your patients are communicating or your colleagues are communicating, तुम 4 बजे मेरा message देखा लेकिन तुमने जवाब नहीं दिया. You did not reply to me. So last scene is always nobody. So they will not be able to see, but at the same time I will also not be able to see. It's all right. Profile photo, if you're keeping it neat and clean, then it's all right for everyone to see. But there are options, like you can keep it into my contacts. So just click on profile photo, mine is everyone, and you can click on out. About, I always keep on everyone because my about is my details, that if the patient is not able to connect to me, I have kept my appointment number in that. And there are people in the groups. So suppose if you don't want to be added to the groups by everyone, you can just keep it to my contacts. So only your contacts will be able to add you in the groups. Or you can keep it to my contacts except also. So these are the some privacy settings. Status is that stories which you put. Happy birthday this, happy birthday that, good morning, something like that. And some people like to put up cases. This is the status on the left side. These are the statuses. So I like to keep my status to everyone except for a few patients whose number I have saved in my contacts. Live location should always be none, whatever happens, because that is a major security hazard. And of course, if somebody is bothering you too much, not listening, these bank people, and many times you must have experienced that patient's relative has shared their report with you, and from next day, good morning, good evening, happy Diwali, happy birthday. So we don't want these messages, so block them. I give them one warning that you don't use this for non-professional reasons, and if they don't listen, second day they get blocked, they cannot ask me. You want to save data on your phone, then you keep the default message timer to 7 days. So in 7 days, all your messages will go. I don't keep it because I like to use WhatsApp as my storage. And of course, the blue tick, that is always off. So if you're communicating with me, Dr. Reddy has been communicating with me, he has never got a blue tick. So sometimes he used to call me. So it's gone, Ollie, again? No? Is the screen back? Oh, yeah. So the blue tick, read receipts. Mine are always off, it is up to you. But remember one thing, read receipts, if you read bottom, that if you put it off, you will also not be able to see. So in Hindi में हम लोग बोलते हैं कि अगर अपना नहीं दिखाओगे तो मेरा भी नहीं देख सकते हो, वैसा है. So it is exactly like this. And if you want more privacy, you can keep a screen lock on WhatsApp. However, I don't like to keep that. I was keeping it, but after the COVID, the mask was causing me a lot of issues, so I stopped keeping it. But in iPhone now, with the mask also, I can unlock. So that is one new feature which you can always keep. So this is all about privacy. Now we go back to my presentation. So just review the privacy which I just showed you. So this is the privacy screen. You have to change the privacy setting. As I showed you, last seen, profile photo, groups, status, block the unnecessary contacts which you don't want. And I keep my read receipts off. I leave that choice up to you. Try it out. If you don't like it, you can always turn it on. And next, we go to what I was just mentioning, that I use WhatsApp as my storage folder. So it has happened, tell me, must have happened to you also. Many times you get up in the morning and you just scrolling through WhatsApp, because that is the first thing all of us do, I'm sure. And then you come across a very nice video or a very nice article shared in one of the groups. And then you get a call from the hospital. Sir, ये patient है, आज OPD है, this है, that है. And then that article is gone forever. You can never retrace it because you don't remember which group was it shared. So what I do is that I have made 2 folders in my WhatsApp, which is my private group. And I send or forward messages to that group, and I can read messages later at the piece. So this is how it is. If you see this, I am the only member of this group. This is a group. So let me show you now how this works. We'll go into WhatsApp and all of us, let's do it together for you to learn better. So let's create a new group, and maybe you create it with your spouse or with your best friend or whatever. So Ashok is here, so I'll create a new group with him, though we have many groups together. So I'll create a new group and I'll maybe name it reading documents, something like that. You can keep it anything. My main group is read later, that's why I'm not creating it the same name. And I create it. So I put one member in the group. So now, if I go inside this group, there are only 2 members. Okay. So now what I'll do, I'll remove Ashok from this group. So now I am the only member. So this becomes your private group. Totally private, and you can just forward all the messages, whatever you get, into this group, and you will be able to read it later. It could be a video, it could be a PDF. Let me show you what I have made my 2 groups. My 2 groups are, one is documents. So these are all my documents for driving license, insurance papers, Aadhaar card, PAN card, visiting card. Even sometime during the COVID, I saved my visiting cards. I used to forward that to my patients. I still do. I stopped carrying my visiting cards, PAN card. So all these things are there related to my documents. So you can store all your documents. Even my mother's, father's, PAN card, everything is there here. So it becomes easy. Hospital registration copy, clinic registration copy, the Gumasta license, whatever you need, everything is there in one. And the other one which I have is read later. which are all my important documents which I want to read. Maybe I'll just forward it here. For example, I wanted to put up an ad for my hospital in the WhatsApp. So I just kept the ad ready. I just copy paste it whenever I need a requirement by editing it. So this is, I am a Sindhi, so this Sindhi national anthem was there. I liked the video, so I just saved it here. At the same time, there are some passwords which I will save here. Then I like this X-ray, so I will save it here for future use. Then this was this workshop which I did, and I saved these messages here. So you can save a lot of things here, like this is our Gita solves a problem. So all these chapters of Gita are there here directly. So there are many things which I have saved, which I can anytime review later on. Of course, you need to have a backup on the Google Drive if you are using an Android phone. If you are using an iPhone, you need to have a backup on the iCloud, because then if you change phones, this all will go away. And now, WhatsApp has other new features. Let me show you one of those new features. So the new feature is a photo. Yeah, you can see it now? Yeah. So the new feature is photo view once. So many times there are some photos which we want them to see, but then we want it to be only once. We don't want them to keep it as a record. So I will show you how it is done. I'll send Ashok a photo. For example, I'll send a photo of this. And I will now put it that he should be able to see it only once. So if you see on the bottom right, there is one written. And when you click on that one, it becomes photo set to view only once. And he will get it. The moment he opens it, I will get a notification that he has opened it. Ashok, can you open the photo? And he will not be able to open it again. So that's it. He will be only able to see the photo once. Of course, he can take a screenshot and everything, but he will be able to see it only once. Most of the people will not be aware, "Arey kya hai? Khol ke to dekha." Then you see photo, gayab ho gaya. It's gone. So it's like, it could be some secret thing which you want to send, I don't know, maybe a girlfriend's photo or boyfriend's photo. Okay. And so this is WhatsApp ka latest feature. What other feature which I like very much is the linked devices feature. You go in the settings and there is something called as linked devices. In the linked devices, if
you can ask both Dr. Sham and Dr. Neeraj. Anyone.
I have an iPhone in which we have one is two SIMs. Physical SIM. Can I have two WhatsApps in a single phone?
Yes, you can have two WhatsApp in spite of not having a SIM card also. You just need an OTP. So one is WhatsApp and one is WhatsApp Business. So two apps.
Two different
yes.
phone numbers are there.
Yes, two different phone numbers, two different apps. So very important that even if you don't have the SIM card in your phone, you can still run one WhatsApp extra on your phone. You can have one SIM card and the second SIM card can mean somebody else's phone or non-existent. If you know my Ortho TV number, try calling me. It's never unavailable because it is lying in my pocket. It is in my bag. I just put it in my phone, took the OTP, started my WhatsApp, and that SIM card is non-existent. That SIM card is only recharged for once a year for just keeping it active. But it is not for calling. So anybody wants to call on my Ortho TV number, they have to make a WhatsApp call. So SIM card need not be there. You just need an OTP to start the WhatsApp.
We request Neeraj to come out to the desk. No, Ashok, sorry, Ashok. I request our Srinivas Reddy, Nagendra Babu sir and Suresh. Please.
Now I request Dr. Ramkumar Reddy sir to honor our chairpersons. Dr. Nagendra Babu sir. Dr. Srinivas Reddy sir. Dr. V. Suresh Kumar sir.
Team TOSACON for inviting me for the second time after Nizamabad, and it's a great opportunity for me again to present our work in this unique platform. So with the due permission of the chairperson, should I start this? Please. Yeah, so in next 1 hour, me and Dr. Pradeep Manoj, we both are here to discuss all foot and ankle queries with 5 unique topics. So I am starting with a very important topic, which is a rotational ankle fracture. Nothing uncommon. We used to see very commonly in our practice. I am Dr. Girish Modwani. I am a foot and ankle surgeon practicing in Nagpur. And this is the simpler case which I am going to start, and I should like to involve everyone in the discussion with the explanation. Okay. So this is a 35-year-old female. She had a simple twisting foot injury, and she has. We are all aware that how to read the Excel, that she has a medial malleus fracture, lateral malleus, and the posterior malleus fracture. And everyone will again agree that these are the fractures where you need more evaluation when you are dealing with a trimallar Cotton's fracture. And most of the time we do the CT scan to evaluate this fracture in a better way, which is giving us the idea about medial malleus, how it is a small chip fracture, lateral malleus fracture, which is Weber B, posterior malleus fracture, displaced and large chunk, and some comminution in the region of fibula. So how to approach this fracture? So without wasting the time, how to approach this? Anything else we need to see on the CT scan, which give us the idea better than what we see on the plain X-ray. Okay, so these are the fractures which usually we manage by the posterolateral approach. This is the approach which is the midline between, the incision is midline between the fibula and the Achilles tendon. So you have to keep the patient in the lateral position. Give an incision depending on the size of the fibula fracture, the posterior malleus. Mobilize the peroneal tendon. You will find the fibula fracture first, and you can plate on the posterolateral surface, nothing new, or you can put a recon plate, and then after securing the sural structures, and then we need to move posteriorly to see the posterior malleus, or vice versa. You can fix the posterior malleus first, followed by the fibula also, depending on which fracture looks simple. This is how, when you mobilize the flexor hallucis longus and the peroneal tendon, you see the big chunk of the posterior malleus. And this is a plateable surface where we usually put a buttress plate, and this is how the case is completed. But not need to forget about the syndesmotic injury, which are sometimes associated 25 to 30% of the time. The trimallar Cotton's fracture, they have been associated with the syndesmotic injury. So in this case, it was a syndesmotic rupture, and this is a small anterolateral incision. To see the syndesmosis directly, you can go with the closed way also, which we will discuss what are the prawns and the crons. But let's go back to the CT scan. What we have missed, and we should look more, is the syndesmotic area, which is like possible only when you look the CT scan in the better way and may not be visible on the plain X-ray. So this is a AITFL, anterior syndesmosis avulsion injury. We call it caput tilox fracture also. So you need to put a osteotome or any kind of bone lever which separates the fibula, and you can directly see that whether it is moving or not in the transverse as well in the sagittal plane. So if it is a syndesmotic instability, it moves the fibula transversely or the sagittally, and this is how you see the reduction through the mini open incision anterolaterally directly. Put a clamp or do the finger reduction, and then you put a clamp again. If it is not moving the fibula, you can fix it with a 2 syndesmotic screw. So this is our routine thing, and this is a final post-operative X-ray. So things which we have learned from the simple X-ray and the simple case is consider the ankle as a circle and always fix all the components of the supination axial rotation injury. Posterolateral approach is our friend. You can address many of things from that approach. Syndesmotic malreduction is again a common, but it's a bad. So it is better you do the intraoperative Cotton's testing or the stress test, and the mini open syndesmotic reduction is better than the closed technique, and it significantly reduces the malreduction rate. But now I am coming to the second part of this talk. Do we need to fix this small postermalus? Because sometimes we are confused that whether to fix the small postermalus or we should fix it indirectly with the syndesmosis. We feel that if you put a 2 syndesmotic screw, everything will come in the place. But let's understand whether it is important to fix it or not. So before that, you need to understand this slide that tibia and the fibula in the axial plane, they has been associated with 3 strong syndesmosis ligament, ATFL, interosseous ligament, and the posterior tibiofibular ligament. Now look at the example, the same example case which we have discussed. This is a posterior syndesmotic gaping because of the displacement of the fracture. And most of the time you feel that this fracture will come with the reduction of the fibula. Yes, most of the time it comes with the fibula reduction, but not always. Because periosteal trapping, organizing hematoma, and there could be some new callus formation because we operate the ankle sometime after 1 week, 2 weeks, depending on the swelling. So it may not be easily movable fragment, and you may not get the advantage of the ligamentotexis always. And this gaping, if it remains persistent after the syndesmotic screw fixation, it is of incongruent ankle. So look at here, if you don't fix the postermalus and directly put a transsyndesmotic screw to address the instability, it affects the healing length of the posterior syndesmosis ligament. Even after the screw removal, that gap remains persistent. Look at the simple example here. Here the surgeon has missed or he has neglected the postermalus fracture, and he put only 2 syndesmotic screw to these 2 syndesmotic screw were put just to make the ankle mortise and to avoid the instability and to fix this instability between the tibia and the fibula. So here the syndesmotic 2 screws, they were just crushed, postermalus was not fixed, considering that it is a small fragment and it will come by its own. So look at the gap here, it's very well reduced syndesmosis in the AP view, but in the lateral, postermalus looks very small, but in little displaced plane. So this is how it is fixed indirectly. Look at what happens after the screw breakage, or this can happen after the screw removal also. The fibula went to its original position because it is just crushed between the tibia and the fibula space, and it is not properly reduced. So this is a reason that you should fix the postermalus and address all components of the injury. Now understand the concept here. When you have a postermalus fracture and when you have a sagittal fibular instability in the syndesmosis injury, it's a bad news. How it is bad? So this is a posterolateral fragment, postermalus fragment, syndesmotic instability. You put a clamp, everything is reduced, fibula is reduced, transmalleolar axis clamp is applied, and now without fixing the postermalus, we are just fixing the syndesmosis, and we are just doing a surrogate fixation to the...
Thank you very much, the President of the TOSACON and the Organizing Secretary and Dr. Srinivas for inviting. So anyway, we have a good gathering even post lunch and people are not sleeping, so that's quite good. Usually foot and ankle kept at this time of the day, you have people dozing off, but I think it's a vigorous middle age. Furthermore, he noted more and more a number of cripples untreated, very often diagnosed as sprains ankles in the early weeks. Even now, if you have a calcaneum fracture which is not united or malunited, a patient is debilitated, he will come to you within 4 to 6 months. He wouldn't wait for too long. So the aim is how do you understand the pathoanatomy? How do you deal with individually the bone, joints, soft tissues as well? So what happens? The force drives the lateral process of the talus into the lateral wall of the calcaneus. The tuberosity moves proximally, superiorly and laterally. The hindfoot height reduces, which affects the lever arm of the calcaneus, flattens the talar inclination, thereby the talocalcaneum angle, thereby affecting the ankle joint movement as well. Lateral side, because there is a translation, fibular impingement happens. Also, there is an increase in the hindfoot width, which results in the lateral exostosis, or the lateral exostosis gives rise to an increased width. And more than 2 mm of displacement changes the load bearing and invariably leads to arthritis in various joints. So that's what pathomechanics happens. So as I mentioned, you have bony problem, joints, tendons and neurologic. We'll go one by one. Let's look at the bone. You have painful exostosis which is happening, which produces problems in shoe wear. You have a widened heel which is called as a Kashiwagi syndrome. Loss of height, which leads to a loss of ankle motion and ankle impingement, and the hindfoot can go into varus or valgus. Joint wise, you have a subtalar and a calcaneocuboid joint arthritis. Occasionally or in the late stage, ankle can also get involved as well. And also there is a calcaneofibular joint impingement. Tendons, usually it's the peroneal tendon get pinched between the calcaneum and the fibula, which can lead to impingement, stenosis or subluxation. Neurologic, usually it's the tibial posterior tibial nerve or the sural nerve because of the significant displacement or because of any bony fragments which impinges. So I just have one case last week I saw in Hyderabad, patient with a big spike on the medial side causing causing a tarsal tunnel syndrome, again because of the calcaneum malunion. Radiographs, all these patients need to be worked up properly. These are not simple cases, so you need to have a good workup of these patients. You need a standing epilateral views of both sides, Broden's views, axial views. So that's a Salzman view. Here you can see on the right side, that's a standing Salzman view. You need to have it. It tells you what is happening in the hindfoot. It tells you it's going in varus, valgus, what is happening with the tuberosity as well. Also, of course, get a CT scan done, and these are usually 1 mm CT cuts. You always ask for the CD. I always ask for the CD. You can play it on your own computer. Look at the angles. Look at the 3D as well. So all that stuff needs to be done beforehand. Now I'll go through it step by step. Classification, as always, everything has a classification. Stephen and Anders, very simple classification. Lateral wall exostosis plus subtalar arthritis, plus a severe deformity. Very simplistic classification. Second is a very exhaustive, self-explanatory classification. We don't use it much. It's the Zwift and Raman classification. Again, depending on arthritis, deformities, loss of height, lateral lines. So this is all a descriptive classification. Our own Indian classification, which is Dr. Rajiv Shah has given a classification which is called as an ADNO. And A stands for arthritis, which is usually the subtalar or the calcaneocuboid arthritis. D is the deformity, how the hindfoot is going. E is the exostosis, usually is the lateral or the plantar. I is if there is any implants or there, we need to deal with that. N is neurological, usually it's a sural nerve or the posterior tibial nerve, and others where usually if it's a soft tissue contractures or toes involved or anything else. So again, descriptive classification, easy to communicate and easy to deal with as well. So coming to the treatment goals, improve the alignment, decrease bony prominences, and finally improve the function by reducing the pain. So what are the things which you can do in your armamentarium? In the bony side, you can do a bony resection. You can do an in situ fusion. You can do a distraction arthrodesis, osteotomies, or a combination. Soft tissues, you can repair the peroneals, you can lengthen the Achilles tendon, nerve neurolysis, and toe corrections. So let's look back to the cases. So this is a chap, you remember the doctor. Now break that down. You have a subtalar arthritis, the bony exostosis are both on the lateral and the plantar side, loss of Giesen angle, which has led to loss of hindfoot height, anterior ankle impingement. You can see almost a flat talus, and you have a valgus deformity. So all these things need to be corrected in your surgery. Okay, so that's your CT scan, lateral calcaneum tuberosity, peroneal impingement can be seen. So extensive lateral approach, plantar side, all the exostosis and the lateral side exostosis has been excised. Distraction arthrodesis has been done, so that gives you hindfoot height. Make sure the valgus gets corrected, which you can see from that my osteotomes. You can see how on the lateral side the heel has been corrected, and that's your final correction with a subtalar arthrodesis. Another case, 57-year-old, history of ORIF done for calcaneum 2 years back. Came to me, doc, I can't even walk. That was the kind of the scar he had, toes affected. There is the scar there, you can see. Hindfoot is bad. X-rays, ankle as well as the subtalar joint affected. Okay, CT scan clearly shows a lot of things. Lateral wall also you can see exostosis, ankle affected, subtalar joint affected, peroneal is affected. Okay, so joint, subtalar and ankle, bony is lateral wall, deformity is valgus, tendon is peroneal, soft tissue, skin. We need to be careful because it's previously operated extensor lateral approach. I got a 3D CT scan model done, did an osteotomy, I knew exactly where I need to plan my osteotomy and where I need to do the correction. So this is all done beforehand. I knew where to do the osteotomy, how will I get the correction, how will I fix it. Okay, so that was done. Hindfoot fusion was done with a nail, and he is a very happy chap. Look at that correction. Third patient, 53-year-old male, 9 months back, calcaneum ORIF done with an extensor lateral approach. Look at the toes. He came with pain, deformity, unable to even walk for around 5 minutes. This was the calcaneum fracture which was done in a big hospital, tertiary hospital in Mumbai. He had a calcaneum malunion, very, very uncommon, very unheard of, but that's what it is. Happens only after you do an open reduction fixation. So joint, subtalar joint, bone, non-union with calcaneum tuberosity and anterior process, hindfoot height is lost, soft tissue, you have a skin and toes which are involved, and implants have to be dealt with. So opened up with an extensor lateral approach. That's the wire in the talus. This is all the pieces. That's a posterior tuberosity, that's a plantar, and that's something in the anterior. We had a big, large chunks of or allografts being put up. Hindfoot height was restored. There you can see these are the whole allografts being put up. And posterior to anterior, length has been maintained, height has been maintained and restored as well. He went on to do very well. So in conclusion, malunion of calcaneum is common. Understand the deformities, what is present. Go through each points of bone, joints, neurologic and soft tissue involvement and deal with them appropriately. Investigate them appropriately pre-operatively so you can plan them, which you can give it good results. Thank you very much.
Thank you, Dr. Pradeep, for your nice presentation.
It's basically a video presentation. So my voice is mute and I'm here to explain the whole videos. It's of 10 minutes, which will contain the Achilles pathology as well as the problem with the retrocalcaneal bursitis. Small description about the conservative treatment, but very important what happens if the Achilles tendon rupture, because this is a term where this is a time where surgeon involvement is high. So yeah, so this is the Achilles tendon and the haggling deformity discussion. So we know that these are the three very common causes of the posterior heel pain: insertional Achilles tendinosis, retrocalcaneal bursitis, and haggling deformity. And usually the combination of all, it leads to the lot of pain. How does the problem happen? First, the problem starts with the bursitis, ongoing inflammation, stimulates the new bone formation, but this is not a healthy bone, leads to the fragmentation of the Achilles collagen, finally healed by proliferation and a big lump, which leads to the further compromise in the bone, and you see a lot of the deformities in the Achilles tendon in the insertion or the non-insertion. These are the various X-ray where we found that the calcification sometimes is up to the level of the insertion, or it may go up to the whole of the tendon depending on what is the pathology. What is the basic treatment? You need to give painkillers, rest, stretching exercise, calf stretching, which is very important, for 6 months. If they are not responding to the treatment, these are the cases where you need to go for the surgical excision of the tendinosis and the Haglund deformity. So this is a 43-year-old female which was not responding to anything. There were a lot of fibrosis, huge Haglund deformity, but the tendon was good, so tendon was lifted up. The Haglund deformity was completely shaved off medially, laterally, and the posteriorly, and a big Haglund deformity was excised to the posterior midline incision. So you need to protect it for the 3 weeks, and but if the tendon involvement is more than 40% and when the size of the defect is more than 3 centimeter after the excision, you need to go for tendon transfer. So this is a 56-year-old female. She had a long-standing posterior heel pain, but suddenly a cluck sound one day, and this was the Achilles rupture, which was a pathological tendon. How to find clinically? She had a very poor plantar flexion stance. Look at here, she is just touching the toe, but she is not able to use the limb for the plantar flexion. So this patient was posted for the flexor hallucis longus tendon transfer. So there are various approaches how to take a FHL tendon transfer, but there are some midline approach and the posterior midline approach. So I take little paramedial incision just to avoid the scar in the midline, to avoid the shoe wear problem, and there are some advantages if you take little posterior medial, because the tendon which is very close, you cannot see the sural now throughout the surgery because it doesn't come with the paramedial incision, and again a scar, as I said, is not at the center. Go with the skin subcutaneous fascia dissection and just identify the two ends of the rupture ends of the Achilles tendon. Try to get a maximum thickness of the flap to avoid the wound necrosis, and once you find the proximal stump of the tendon, you will find that, look at the white and the red zone, because, or the yellow and the red zone. This is how you can identify where is my diseased area and how much I need to cut it. So you have to identify the disease and the normal zone, and then distal stump you have to excise completely, except for some of the footprints where you can remember that where I need to put my FHL tendon for the replacement of the Achilles. Now cut the yellow and the red zone, because this is an area which is painful. So you have to cut the tendon completely because this is a diseased tendon. If you repair anything on top of that, it will be, the chances of re-ruptures will be high. So look at the defect here, the size is more than 5 centimeter. So how can you bridge the gap then? So one of the good option is you take the FHL tendon and do it. Any osteotome, just put it to the Haglund, identify the Haglund deformity, how much you need to take out with the mini saw, and after removing the Haglund deformity and all the sharp edges, you will find that these are the pure cancellous bone, bleeding cancellous bone, and then you have to go little posterior medially, identify the tarsal tunnel, and you will find the big, large belly going inside the tarsal tunnel, which is flexor hallucis longus. So you can identify that it has a very long belly and a small tendon visible through this approach. But if you move the great toe, you can identify, no, this is my FHL, and not get the confusion with FDL tendon. So these are all the structures going inside the tarsal tunnel. Out of them, the most outer structure is the FHL tendon, which you can identify easily by just moving the great toe. So this is, see, I'm moving a great toe. So put a small mini the scissor and just separate it. You can use the tendon stripper also, and just 5 to 6 centimeter of the tendon length is very important. You can put the tendon stripper also, but make sure you are not injuring the neurovascular structures. Or you can use the the 15 number blade and just take the 5 to 6 centimeter, 4 to 5 centimeter of the tendon length, so that it should go, that much amount of the length should go inside the bone while fixing it. Do the maximum great toe flexion when you are cutting a FHL tendon in the tarsal tunnel, because this gives you the maximum length of the tendon available. So this is how you need to separate with the 15 number knife, and with the Krakow stitch or through the shoelace repair, anyhow you can put a fiber wire or the number 2 the ethibond to take the tendon. You separate the sheath of the belly so that you get a more length of the tendon. Just hold it with one cocker or Alice and separate the FHL belly, which is a very thick belly proximally, from the underlying structure. So this is how, when you stretch it, you'll get some 2 centimeter additional length. Provisionally, you can put it on the heel in the 10 degree equinus, or you keep the opposite side in the equinus and just compare that with what position you need to fix it. 2 fiber wire, Krakow stitch or the shoelace, any kind of tendon holding procedure you can do. Just a strong stitch to take hold of the tendon, and if you have 4 to 5 centimeter of the length, that is usually enough. It is a short tendon harvest. This much amount of the tendon will go inside the bone. So this is how accordingly you have to plan your drilling. We are preserving the footprints of the Achilles tendon. So from posterior superior to the anterior inferior, you have to put a guide wire, and this will now act as an Achilles tendon. So the phase of the contracture of the FHL should be close to the previous side. Identify the size of the tendon, and accordingly you can plan your drill bits. One size bigger than what you had, and of same size you have to use the screw. So this is how you have to drill the tunnel. You have to make the new tunnel from superomedial to plantolateral, and this is how you need to pass the tendon inside the tunnel. It should be freely movable. There should not be any bone pieces of the cancellous bone which hinders or affect the movement of the tendon inside the tunnel. And now you can use the interference screw by keeping the tendon inside the tunnel in 10 to 15 degree equinus position, or comparing to the opposite side, and you can use an interference screw or suture anchor, or there are many ways to fix this structure. So here commonly we use the interference screw. This is how the on-table stability. Now it will completely replace the function of the Achilles tendon, the proximal stump of the Achilles tendon, because if you don't repair it, it will go into wasting and it will lead to calf shortening. So proximal stump in the maximum stretch position you have to repair to the transferred FHL tendon. This is how 4 to 5 centimeter incision is usually required to do this surgery, and this is the on-table Thompson, where you get some positive movements of the ankle, and you have to repair the soft tissue usually in 2 layers with 2-vicryl and ethylone, tension-free suture, and post-operatively these patients you need to give a soft dry dressing and an anterior slab with a 20 degree equinus position. And this is a post-operative order which is different for different people, but I have followed 20 degree equinus for 3 weeks with the neutral for next 3 weeks, and 2 months full standing sports, return to sports 6 months. Thank you.